Hello, and thank you for joining me for this review of the medications that we use to manage rheumatoid arthritis. I am Dr. Amber Cann. Let's jump right in. I will give you a moment to review the learning objectives that we will cover in this video. A quick editing note, you also may hear the sounds of dog snoring, clinking sounds of their collar tags, and various doggy sounds. There are also birds outside of my window, and you may hear them delightfully twittering outside. My most prolific snorer is Ruby, but my other furry coworkers may make an appearance in the audio of this lecture. I hope you don't mind. First, a quick review of what rheumatoid arthritis is. It's a systemic inflammatory disease. Not only does it involve the joints, which is what we usually think of, but it also has a lot of extra articular involvement. There's an autoimmune process going on, and it can lead to progressive physical disability if not treated early and aggressively. Some patients have a chronic type of disease, and others enter remission spontaneously. The primary cause of disability in RA patients is the joint destruction. You can see here that a joint that is affected by rheumatoid arthritis has a swollen joint capsule, the synovium is inflamed, and there is bone erosion. An autoimmune process is when the immune system fails to recognize self as self. The immune system is designed to discriminate between self and non-self. That's how we fight off infections. In autoimmune diseases like RA, the system no longer can accurately distinguish between self and non-self. The immune system effectively begins attacking our own body's tissues, recognizing them as foreign. RA often involves the small joints of the hands and the feet. Typically, patients will have stiffness early in the morning, and as it progresses, the patient experiences a lot of range of motion loss, atrophying of the muscles, weakness, and deformity, similar to one you see there called the swan neck deformity of the hands. While RA most frequently attacks the wrists, the hands, elbows, shoulders, knees, and ankles, really all joints could be affected, and it usually happens symmetrically. As for other systems affected by RA, some patients experience fibrotic effusions in their lungs. They are at increased risk of cardiovascular mortality, and they may experience skin breakdown and ulcers due to vasculitis, and their eyes may be affected because of atrophy of the lacrimal ducts. These two photos show the progression of rheumatoid arthritis. On the left hand, we see a young woman's hand, and the joints are slightly inflamed and larger in the middle sections. On the right hand photo, we see an old woman's hands that have been majorly affected by RA. You can see that swan neck deformity of the hands and also the nodules that are very much inflamed. When we treat RA, the first thing that we aim for is low disease activity and, if possible, remission. We also want to maintain and improve functional status, control joint pain, improve the patient's quality of life, and slow the overall destruction of the joints. Non-pharmacologic therapy should be a part of any treatment plan. For RA, we recommend frequent rest periods to allow the joints to heal, occupational and physical therapy for patients. Some people may need assistive devices to help maintain their joint functioning. If the patient is overweight, reducing weight can help with overall health. And we do need to encourage family and social support because the patient will be experiencing pain and loss of function as a result of the disease. Some studies have suggested that Fish oil may help with pain and stiffness by reducing inflammation. Before suggesting this or prescribing it for a patient with RA, you should check the interactions to make sure that the patient's other medications will not be impacted by the fish oil. Medication management of RA can be thought of in 3 different categories: supportive agents, DMARDs, also called disease-modifying anti-rheumatic drugs, and the 3rd category is biologics. Let's first dive into the supportive medications we use for RA. I want to first emphasize the importance of up-to-date vaccinations in patients with RA. Before starting treatment, it is recommended that the patient receive a pneumococcal, influenza, Hep B, HPV, and herpes zoster vaccinations. It is very important never to give live vaccines to a patient with RA. The first category of medications that we use for supportive or adjuvant care in patients with RA are the corticosteroids. They can be used for acute flares of symptoms, and they can be used for control of symptoms before the DMARDs have time to work. They are available in an oral dosage form as well as injectables that can be given IM, IV, or even intra-articular. We always want to use the lowest effective dose that gives the patient relief. And low dose usually means less than 10 milligrams of prednisone or its equivalent. The non-steroidal anti-inflammatory drugs are the second type of supportive therapy that we use in RA patients. Patients can have a variable response to different NSAIDs, and a trial of about 1 to 2 weeks before switching medications is always advisable. NSAIDs should never be used as monotherapy because they don't affect the course of the progression of the disease. You need to weigh the risk versus benefit in every patient because NSAIDs put the patient more at risk for GI upset, bleeding disorders, kidney function decline, and cardiovascular events. Now let's talk about the disease-modifying anti-rheumatic drugs, or DMARDs. If we're treating a patient that is early in the progression of the disease, and the patient has never received a DMARD before, Methotrexate is the drug of choice, and it can be used as monotherapy. If symptoms are not controlled adequately with just Methotrexate, then we can consider to add on another medication. If the patient has established RA and has been diagnosed for some time but still has not received a DMARD, Methotrexate is still the drug of choice. We can add secondary therapy to the Methotrexate if symptoms aren't controlled. And the difference here is that there's one extra option that we can use when the disease is progressed. If symptoms are mostly controlled and the disease activity is low, then we should continue therapy at the lowest possible doses to maintain this state. If the disease is in remission, we should not discontinue all therapies, but we can consider a slow taper of most of the medications the patient is on. Let's talk about the specifics of DMARDs. The category of DMARDs includes the medications Methotrexate, Hydroxychloroquine, Sulfasalazine, and Leflunomide. Methotrexate is often abbreviated MTX. It works by inhibiting dihydrofolate reductase, thereby halting DNA and RNA synthesis. The efficacy occurs with an onset of about 2 to 4 weeks after the first dose, and a maximal effect in 1 to 2 months. No drug used as monotherapy has been shown to be superior to Methotrexate. This is why it is always first-line therapy for RA patients. It's important to note that Methotrexate, regardless of its dosage form, is given on a weekly basis. This is so important to stress to patients. The dosing is typically between 7.5 and 25 milligrams every week. Even though methotrexate is our first-line best option for patients with RA, there are a lot of safety issues that you need to be aware of. They can cause a lot of gastrointestinal disorders, stomatitis, hepatotoxicity. Mainly, we think of when we're prescribing the folic acid deficiency. We always should give folic acid supplements along with methotrexate. Methotrexate is definitely a pregnancy category X, so it should never be given to a woman who is pregnant or is even thinking of conceiving. If a patient has a liver disease, is an excessive alcohol user, has kidney disease to where their creatinine clearance is below 30, they have any kind of blood dyscrasia or active infection or another type of immunodeficiency, they should not receive methotrexate. When you're prescribing methotrexate, you should be thinking about laboratory monitoring at baseline and at intervals in the future. You should have a full liver panel prior to prescribing, a CBC and a serum creatinine. That will let us know if they have any contraindications for selecting methotrexate for therapy. Methotrexate is the DMARD of choice. It's low cost. It's got a proven effectiveness record, and we know that it works better than a lot of other options that are more expensive. I just mentioned that you should always prescribe folic acid with methotrexate. The reason for that is that the inhibition of the dihydrofolate reductase results in inhibition of folic acid metabolism. So when we give methotrexate, we should always co-administer folic acid about 12 to 24 hours after each methotrexate dose. In doing so, we reduce the GI effects associated with methotrexate use, and we don't reduce the efficacy of methotrexate. That's important. We also want to prevent long-term consequences of folic acid deficiency. So the standard of care here in the United States is that with methotrexate dosing, we also prescribe folic acid 1 milligram PO daily. That's a daily dose with the folic acid along with the methotrexate weekly. The second option that we have that is also a DMARD is a drug that has gotten a lot of press in this age of COVID-19. That drug is hydroxychloroquine. It is another DMARD that has been traditionally used as an anti-malarial medication. The brand name of that is Plaquenil. The way that it works is it seems to interfere with antigen presentation on red blood cells, and it also inhibits metabolism of deoxyribonucleotides. So that's how we use it in RA, is because its effect on DNA synthesis. Its efficacy is modest, not as good as methotrexate. It has a slower onset, and it's rarely used as monotherapy. So it's mostly used in combination with other DMARDs, and it's not first-line therapy. The main things you have to think about with hydroxychloroquine are the safety issues. As with methotrexate, this is a very toxic medication when used even at recommended doses. The main thing you have to worry about is retinal toxicity, and patients who are on hydroxychloroquine for RA should get regular eye exams. If they have any concurrent ocular disease, they should never be put on hydroxychloroquine. The third DMARD that we have in our tool belt is a prodrug. It's called Sulfasalazine, and when it is administered, the bacteria in our gastrointestinal system cleaves off two different chemicals. One is 5-aminosalicylic acid, and the other is sulfapyridine. The sulfapyridine is what we are interested in for use in RA. The way that it works is it suppresses T cell response and B cell proliferation. That is helpful when there is an autoimmune disorder going on. It's moderately effective, more so than hydroxychloroquine, but less so than methotrexate. And it takes a long time to see a response, probably 6 to 8 weeks. You may recognize this drug as one that we use in another autoimmune disorder, inflammatory bowel disease. Because of the drug being cleaved into two different chemical entities, one is a salicylate, the other has a sulfa component. You would never want to administer sulfasalazine to a patient who has an aspirin or salicylate allergy or someone who has a sulfa allergy for that reason. This drug has a dose-related toxicity, so the higher the dose, the more likely you are to get toxicity related to the GI system, leukopenia, hemolytic anemia, and megaloblastic anemia. One thing that patients might alert you to a toxicity is urine and skin discoloration. As with the other DMARDs, you would want a CBC at baseline, and you need to be checking a CBC every week for 1 month. That is because of the blood dyscrasias that could occur with sulfasalazine. Its role in therapy is it's always used in a combination with another DMARD. It's never first-line therapy. Our next DMARD that we use decreases lymphocyte activation, so that's helpful with autoimmune disorders. That drug is Leflunomide. The brand name of that is Areva. It's a relatively newer drug. Its efficacy is similar to Methotrexate, and it can be used in monotherapy or in combination with another DMARD. You get a response in about 1 to 2 months, which is significantly a less amount of time than the other DMARDs that we've spoken about. Leflunomide is definitely a pregnancy category X. This is true for both females of what childbearing age and also males who might be with a patient who is thinking about conceiving. So you would want to inform patients that are male and female about the risks of using it in a pregnancy or conceiving situation. If a male or female wants to stop taking leflunomide, they can do a 11-day washout with a drug called cholestyramine. That's something that we use for hypercholesterolemia, and it happens to be very good at flushing out leflunomide from the system. We also need to confirm that the drug is no longer in the serum with drug levels before we prescribe it to a male or a female who is thinking of conceiving. This being a drug that works on the immune system, we can get a lot of toxic effects even at the doses that are recommended for RA. You can see an elevation in liver function tests, loss of hair, skin reactions, GI effects like diarrhea, and even bone marrow toxicity. So it's something that we want to monitor very closely when we're giving this to a patient with RA. To monitor a patient on leflunomide, we want LFTs on a regular basis. We want a Hep B and Hep C study and a definite CBC on a regular basis. As for its role in therapy, it is an alternative to methotrexate. So for patients who are methotrexate intolerant, it has a similar efficacy to methotrexate. It can be used in combination therapy. So it's a great alternative for people who can't take our drug of choice. I've had students tell me that they think of this name as log-flumomide. So that is why we see a picture of the rock on a log flume. We'll now switch gears and talk about biologic RA agents. These are different than DMARDs, and they have different mechanisms of action. We split the biologics into 2 categories. One is the TNFI, that is the tumor necrosis factor inhibitors, or the non-TNFIs. So first let's talk about the TNFIs. The names are difficult to pronounce, but let's get through them. First of all, what are biologics? Well, they're genetically engineered protein molecules, and they block pro-inflammatory cytokines. So the various ones we have, the first one we'll talk about are the TNFIs. They block tumor necrosis factor. Another type blocks the IL-6 type of factor, interleukin 6. Some of them deplete peripheral B cells. Some prevent activation of T cells. And the last category we'll talk about are those that inhibit the Janus kinases. Where do the biologics fit in the place in therapy for rheumatoid arthritis? Well, they may be more effective than DMARDs when the DMARDs fail to provide an adequate response, but they are considerably more expensive, and the risk of infection, increased incidence of tuberculosis. There are downsides to them, of course, but when you have a patient who isn't responding well to a DMARD, this is our next option. Let's jump into the first category of biologics, the tumor necrosis factor inhibitors, or TNFIs. You can think of these names with an acronym, ICE-H. We have Infliximab, Certolizumab, Etanercept, Adalimumab, and Golimumab. To make the acronym work, I put Etanercept there again at the end. You can see from this chart that TNFIs have a lot of uses, and rheumatoid arthritis is one of them for each of the drugs that I mentioned. If you look on all of these drugs, they do have some differences in what they are approved for. RA appears in all of the approved uses for the tumor necrosis factor inhibitors. With all of the TNFIs, there's lots of warnings you need to think about before prescribing. The first of which are infections. The patient is more at risk for lots of different infections, opportunistic infections, fungal infections, and even TB. So screening prior to prescribing is so important to make sure the patient does not have a compromised immune system or does not have an active infection. Patients that are taking TNFI drugs are at increased risk of cardiac mortality. The risk versus benefit in patients with CHF is even more tricky. Patients with any kind of cardiovascular disease, including CHF, would need to be monitored very carefully. In patients with MS or any kind of neurologic disorder, history of cancer, these are all things that would definitely need to be weighed in the risk versus benefit when prescribing a TNFI biologic drug. Let's talk about the risk of infection with biologics. Patients that are on these medications are at much more increased risk of infection. Patients shouldn't receive any live vaccine while they're receiving a biologic RA agent. And those who develop an infection should discontinue temporarily their biologic medication until the infection resolves. It's also a good idea, standard practice here in the U.S., to get a PPD or TB test placed and read and negative one prior to starting biologic therapy. Infliximab is one of the first biologics that we'll talk about. Brand names include Remicade, Inflectra, and Renflexis. It works because it is a chimeric monoclonal antibody and it binds to soluble and membrane-bound tumor necrosis factor alpha. Basically what it does is it halts progression of joint damage. That's its primary effect that we like it for in RA. It must be used in combination with methotrexate. That's why if I put the X in red there so you can remember that with the methotrexate, we use Infliximab. It is not used as a single therapy. Biologics are often dosed similar to what you would think of chemotherapy dosing to be like. Infliximab is given as an IV infusion at weeks 0, 2, and 6, followed by a maintenance infusion every 8 weeks. So of course, this isn't something that the patient is administering him or herself. It's usually done in an office-based setting or an IV infusion clinic. To minimize the amount of infusion-related reactions, we often administer a pre-medication regimen. So that includes Tylenol or acetaminophen, diphenhydramine, and some steroids. The slower the infusion, the less likely we are to have infusion-related reactions as well. Some of the things that patients experience when getting therapy on Infliximab are nausea, flu-like symptoms, and rash. The next medicine we'll talk about is Etanercept. It is known by the brand names Enbrel and Orencia. It binds to TNFs, preventing them from interacting with their receptors. Remember, those are inflammatory cytokines. For the efficacy, it helps with reducing joint inflammation, slows the erosive process that we see in joints in RA, and it does so at a better rate than MTX or methotrexate. So that's a benefit that it has. Its onset is in about 2 weeks, and we'll usually see a maximal response in about 3 months. A big difference that we have with Etanercept versus Infliximab is it is a self-administered subcutaneous injection. So patients can administer this to themselves at home. It's a twice-weekly dose if it's a 25 milligram dose, or the 50 milligram can be given once weekly. Some patients complain about a skin rash or an injection site reaction, but for the most part, etanercept is very well tolerated. The next TNFi biologic we'll talk about is adalimumab. You may know this by the brand names Humira, Amjevita, or Siltazo. It works to impair cytokine binding. It's less antigenic than infliximab, so that has a benefit. And the other benefit over infliximab is that it is a self-administered injection, subcutaneous injection. So it's similar efficacy to other anti-TNF agents. Its onset is within a month. The next two TNFIs are particularly hard to pronounce. I'll give it my best shot. Golimumab is known as brand name Simponi. Maybe you remember that by the picture of Gollum in Lord of the Rings riding a pony. The other is Certolizumab Pegol. It's known by the brand name Cimzia, and they both are human antibodies to the tumor necrosis factor alpha. They have a similar response to the other TNFIs. They're used in combination with MTX or methotrexate. They are not single therapy drugs. Golimumab is injected monthly, and that can be self-administered by the patient. Certolizumab is injected every 2 weeks, and that one is also patient-administered. Now we will move on from the TNFIs to those that don't fit in that category. Still biologics, but they do not work on tumor necrosis factor. Here's a handy acronym to remember the non-TNFI biologics, ATART. These work in those various ways that we mentioned earlier. First, there is anakinra. We have Tocilizumab, Abatacept, Rituximab, and finally Tofacitinib. The first one is anakinra, or Kineret. It works on interleukin-1 and it antagonizes the receptor for IL-1. Most of the data on this drug indicates that it may be less effective than the other options that we have, so it's not yet included in the published recommendations for rheumatoid arthritis. It has some limited use. Some patients may benefit if other drugs aren't quite working well. But like Anakin Skywalker, it seemed to have a lot of potential when we first got to know it. Then, as we got to learn more and more studies were done, we just don't seem to have much use for it now. Tocilizumab is Actemra. It works on interleukin-6 by antagonizing that receptor system. It's an IV infusion or a sub-Q injection, so it does have some flexibility there. We definitely do not initiate therapy if the patient has an ANC below 2,000, a platelet count below 100,000, or LFTs over 1.5 times the upper limit of normal. When this is administered in a clinic setting, usually the pharmacist will confirm these lab values before dispensing the product. We need to monitor CBCs, LFTs, and lipids, of course, with this medication. I've inserted another drug here that I didn't have in my previous slides because it's relatively new but not yet in the guidelines. That is Seralutinib or Kevzara. It also works on IL-6 as an antagonist. It's indicated for moderately severe RA with an inadequate or intolerant response to one of the DMARDs. So definitely not first-line therapy for Seralutinib. Dosing of this one is subcutaneous every 2 weeks. I include this picture because I just want to point out that these self-administering products are becoming ever more patient-friendly. This one is a pen that the patient injects. This is the Seralutinib. It's ergonomically designed so that patients who traditionally have difficulty with RA holding a pen or maneuvering their joints, this one's designed to where it could be easier for those patients. It does not have a button to press, which is also a difficult maneuver for patients who have painful RA and swollen joints. The cap has a loop on it, which is easy to grab when patients have difficulty maneuvering small, fine movements with their fingers. And there's a grip on it for easy handling as well. These dosage forms are becoming ever more patient-centered, and I think that's a great innovation, along with developing new drug entities as well. Abatacept is known by the brand name Orencia. It works on T cell activation. It can be used as an IV infusion or a subcutaneous injection. It's weight-based dosing, which is different from the other products that we've talked about. It's dosed similar to chemotherapy regimens at weeks 0, 2, and then every 4 weeks. Rituximab or Rituxan works to deplete peripheral B cells. It's only used as an IV infusion, so not something the patient administers himself or herself. We must pre-treat with a regimen to reduce infusion reactions. So generally we'll give something like a steroid, methylprednisolone, some antihistamines like diphenhydramine, and acetaminophen. Tofacitinib or Xeljanz is one of the very newer medications in this category of biologics. It inhibits intracellular Janus kinases. Therefore, you can see the Jan in the brand name there. The big innovation with this product is that it is PO, it's oral dosing. There's an immediate release dosage form. It's 5 milligrams orally BID. The extended release is 11 milligrams PO once daily. So this is a huge innovation for patients. It doesn't require an injection. It does require a dose reduction for patients who are on strong cytochrome P450 3A4 inhibitors, and that list is a long list, so something to be aware of. Then we also have to dose adjust in cases of severe liver or kidney impairment. The safety and adverse effect profile is similar to the other drugs we've talked about, as is the monitoring parameters. Here's another product I didn't mention on my previous slides because it's really new. It's similar to the previous product that we just talked about. It also inhibits intracellular Janus kinases. It is Baricitinib. The brand name of that is Olumiant. It's also PO, so a great innovation for patients who have RA. It's very similar to Tofacitinib in its drug interactions, its need for dose adjustments in kidney and liver failures, and the side effect and adverse effect profile is very similar. That was a lot of information. So let's put it all together by reviewing some patient cases. Barb is a 63-year-old female recently diagnosed with RA. She's in your office today with complaints of continued pain and swelling in both of her hands, her elbows, and her knees. She says she gets some relief from her current regimen, Methotrexate, 15 milligrams PO once weekly. She's been on this for about 3 weeks. What is the most appropriate therapeutic option for Barb at this point? Here are some options for Barb. Should we continue her Methotrexate and initiate Leflunomide with it? Should we discontinue her Methotrexate and initiate Infliximab? Or should we continue the Methotrexate and initiate folic acid? Or should we discontinue her Methotrexate and initiate Rituximab? What do you think? If you recall from our Methotrexate information slide, we can see an onset of Methotrexate in about 2 to 4 weeks, but we really don't see a maximal effect for 1 to 2 months. I really don't think that Barb has had enough time on the Methotrexate to see if it's going to work for her or not. So discontinuing her Methotrexate is really not wise at this point. Since we don't know if it's going to reach its maximum effectiveness, it's not wise to add an additional therapy before we see how the Methotrexate is going to work for this patient. We also didn't see on her list of medications that she's taking folic acid with her Methotrexate. Remember, always with Methotrexate, patients should be receiving a folic acid supplement. So the most wise course of action for Barb is to continue her Methotrexate and make sure that she is taking a daily folic acid 1 milligram supplement. Now we have the case of Jane. She is a 53-year-old female diagnosed with RA in her 40s. She reports continued pain and swelling in both of her hands, her elbows, and her knees. She says she gets partial relief from her current regimen, which includes the following: prednisone 5 milligrams PO daily, Methotrexate 15 milligrams PO weekly, and folic acid 1 milligram PO daily. She's been on this regimen for about 8 months. So what's the most appropriate option to provide further benefit for Jane? Do you think we should continue her methotrexate and initiate sulfasalazine? Should we discontinue her methotrexate and initiate infliximab? Or we could continue her methotrexate and initiate anakinra. Our fourth option is to discontinue the methotrexate and initiate hydroxychloroquine. Let's take a look at our algorithm for treating patients with methotrexate. So this patient isn't DMARD naive, but she is early in her symptomatic journey of RA. She's only been on therapy for 8 months. We started her with DMARD therapy with the methotrexate as monotherapy, but we see that after some time has passed, her symptoms are not quite controlled and her disease activity is still present. So at this point, we could add another drug, a DMARD combo. We could add something to the methotrexate like a TNFi or a non-TNFi biologic. So given this algorithm, let's go back to our choices. Well, like before, we really haven't gone all the way with the methotrexate. So I don't think discontinuing the methotrexate is wise at this point in time. We're left with the two options of continuing the methotrexate and then adding something. So our two choices here are the sulfasalazine, which is another DMARD, and the anakinra, which is a non-TNFi biologic. On the basis of cost alone, adding sulfasalazine in addition to the methotrexate is the wisest choice. The anakinra, as you may remember, has not proven to be a blockbuster drug in controlling symptoms, and it is quite expensive. Sulfasalazine, on the other hand, is an old drug. It is effective as dual therapy with methotrexate, and it's certainly less expensive for the patient. Now we have our third patient, Brittany. She's a 39-year-old female with RA diagnosed 2 years ago. She continues to have persistent inflammation in her hands and an hour of morning stiffness. Here's her current medication regimen. She takes methotrexate with folic acid. She also has dual therapy with her methotrexate in the Leflunomide. She takes naproxen for occasional inflammation flares, and for occasional GERD and heartburn, she takes lansoprazole. Her radiographic evidence shows signs of progressive joint space narrowing and bony erosions. What do you think is the most appropriate next step in the treatment for Brittany? Should we discontinue her MTX-LEF dual therapy and add minocycline? Should we add prednisone as bridge therapy? Should we discontinue her LEF, add anakinra and etanercept? Or should we discontinue her LEF and add etanercept? Let's eliminate choice A right now. I'll add that minocycline in the past was a drug that has been used for RA. It's an antibiotic, actually, but it does have some anti-inflammatory properties. And because we have so many more drugs that are much more effective, minocycline is no longer used. So let's just eliminate option A right now. Prednisone is used as bridge therapy between the time when we initiate a DMARD to the time when it takes effect. This patient's been on her therapy regimen for 2 years now, so we're really past the point where prednisone could be used as a bridge. Let's eliminate option B. Reviewing our algorithm for an established RA patient, we are at the point with Brittany where she's on a DMARD combo. She's on the methotrexate and the Leflunomide. We have several other options that we could try with her. I think the best option here is continuing her methotrexate and then initiating either a biologic TNFi or a biologic non-TNFi. Because she's an established RA patient, we also have the option of starting her in dual therapy with methotrexate and the Tofacitinib. So I think it's wise to stop a dual therapy regimen of 2 DMARDs and add a biologic. Hopefully you recall that we never put a patient on 2 biologics at the same time. Dual therapy with 2 biologics strictly contraindicated. But biologics are often used with a DMARD in combination. So we can eliminate option C there because we don't want to add 2 biologics concurrently. That leaves us with our option D, discontinuing the Leflunomide, adding a biologic in the form of Abatacept. Great job on those cases. I'm hoping that you will use your algorithms and the logic that we have laid out to form a treatment plan for any patient that you come across. The treatment key points here is that treatment is determined by whether the patient is early or established in their disease and whether they're experiencing disease activity. Methotrexate is always first-line therapy for any patient starting RA therapy. And we often keep methotrexate while adding other options as dual therapy. Biologic agents are often used in patients who don't respond fully to MTX, and we can use them and combine with other DMARDs if a patient can't take methotrexate at all. But we never ever use two biologics concurrently. So let's bring it all home in a summary. Rheumatoid arthritis is a systemic disease. It's characterized by inflammation of the joints, but involves a lot of other organ systems. Controlling inflammation is key to slowing the progression and managing patient symptoms. NSAIDs and corticosteroids are used as adjunctive therapy for early stages of the disease and for flares in established cases. They are never ever used for monotherapy. When one DMARD is ineffective or inadequate, we always go to combination therapy with a DMARD. We can add biologics onto DMARDs or use two DMARDs together. It's so critical to remember that drug therapy is only one facet of a comprehensive management plan for RA. We should also be managing patients in a way that takes into account the whole person, recommending physical therapy, giving them options for exercise and rest, suggesting assistive devices if they need them, and surgery when appropriate. It's so important that RA patients be up to date on their vaccinations. They're just more at risk for lots of different opportunistic infectious diseases, and we can mitigate that risk with up-to-date vaccinations. However, remember, they should never receive live vaccinations. We should also carefully monitor the efficacy of the medications that we prescribe, and regular monitoring is so important. Thank you for joining me for this review of the medication management of rheumatoid arthritis. I am Dr. Amber Cann.